I would to disagree a little bit with Lawrence. So the way that it works is that our U.S. drug supply chain is very convoluted, and it definitely needs reform. And there is something known as an invisible middleman, or pharmacy benefit managers. For example, CVS has Caremark, and they. So a normal supply chain would be, let's say Coca-Cola, for example. There's a manufacturing unit, and then they ship the product to the retail store, and then the consumer goes and buys it. And then some of the money's kept by the retailer, and then goes to the wholesale. Well, that's not how it works for a drug supply chain, because the drugs that are made by the pharmaceutical companies are then given to the pharmacies, but we have something called a third payer system, where a third payer system in our healthcare, where Medicaid, Medicare, TRICARE, VA, and employers are the ones paying our healthcare purchases. We don't go to the store and just buy a product. It's mostly covered by insurance, especially drugs. So we have a third party managing the payment. So there's a disconnect between the consumer and the person who's actually selling it. And so the pharmacy benefit manager negotiates with the pharmaceutical company and gets rebates, secretive rebates that we don't know about, kickbacks. And depending on the deals that they cut, the drug goes up or down a list. It's called a formulary, whether it's third tier, fourth tier, 1, 2, or 3. And if they make a good deal, it goes up. If it goes to the top tier of Medicare, that means Medicare will cover most of the costs, and the consumer will only cover like a little bit in the copay. But if they don't make a good deal, it'll be at the bottom of the list, or maybe not on the list, and then the consumer has to pay a lot. So it's basically backroom deals. It's very, very convoluted. The Trump administration has called, at least it said, that they wanted to eliminate the middlemen altogether, but lobbyists pressure the cycle of DC, so they remain. But I would say that you have to audit them, demand transparency, and say, okay, well, if the list price of a particular drug is so high, what percentage is going into the pockets of the middleman? What percentage is going to, as sort of a bribe to Medicare, Medicaid, and all those places? There's a lot. It's very, very complicated, and that would be the way to reform it. We can't, price controls are bad, because price controls, that's basic economics 101. When you stop the price, artificially stop the price of something, you risk drying up the supply of the product. And European nations put these price controls and dry up the supply, which is why, as I said in that study, only 10% of Europeans had access to the newest generation of antipsychotic drugs, and this was back in 2002. There's a disconnect between, we can't have those price controls. That would not work. Having price controls also jeopardizes bringing a drug to market. It's always a big risk and a gamble to develop a new drug. It takes $1 billion to bring it to market. And if you have a price control, it's a type of a regulation that would also stop people from taking that risk, because it's high risk, high reward. So
I agree that